Welcome guest panelists and speakers to the second session of APHRS Asia IPAC 2022 SVT module, Frontiers in SVT Management, a new series of learnings. We have with us distinguished panelists to attend this session. Thank you for attending. I hand over the session to Dr. Balbir Singh, who would do his welcome address, and he will also give a small recap of session 1. Over to you, sir.
So good morning, good afternoon, or good evening, wherever we are. So as we discussed last time, that these sessions are very practical sessions to introduce SVT to all levels of operators, for young operators doing new ablation procedures, for the most experienced. As we would recollect from the first session, which was Professor Lim and Professor Sam Asirvadan, we had discussed about the basics of ablation, and I would have one question for Hiroshi, who was the inventor of the cool tip or irrigated tip catheter. So we learned about the basics of RF ablation, RF energy, new forms of energy, cryo, pulse field ablation, and we look into the future of pulse field ablation as we move on from RF to more new modalities of energy to treat arrhythmias. And it was a very interesting session. The second session was anatomy of the bicuspid annulus, atrial flutter, the problems and challenges of having a multipolar catheter placed at different parts of the atrium in atrial flutter, dual loop atrial flutter. We discussed all that. And in the SVT, we discussed what Jackman, Hiroshi, and Sam had described as the extensions of the AV node, the inferior extensions, the superior extension, the tendon of Todaro, how the anatomy correlates with the catheter placement. And it was really a very, very nice way of understanding the anatomy of SVT. As we go into the next session, this session is equally important. And now we start the real EP with this session. We have Hiroshi, who was one of the pioneers of parahesian pacing. And I know all of us make a lot of mistakes in doing parahesian pacing and interpreting the results. And here we have a lecture from the master on what is parahesian pacing about and how do we do it practically. And Hiroshi is going to continue his talk with some atypical accessory pathways, again, which we know, but we sometimes misdiagnose and mess it up in the EP lab. So these are two very important areas for anybody who's doing an SVT ablation. So as we go into the second session, we have this followed by Narasimhan. Narasimhan is going to have a very important talk in this whole meeting, which is diagnostic maneuvers for SVT diagnosis, because all is not AVNRD, all is not a left accessory pathway. There is much more to understand and do. It should not be complicated, but it should be done rightly, so that at least a couple of maneuvers should clearly tell you where the diagnosis is going to end up with. Next slide. So Hiroshi is a great teacher and a great man. He's a wonderful man, and I attribute my first 3D mapping learning from him, and I still remember the cases that we did together. And had it not been for him, I wouldn't have been so accomplished in 3D mapping, because he's such a perfectionist that he won't accept any point which is wrongly taken or wrongly labeled. And it is a great learning. But the great thing about Hiroshi is very humble, very down to earth, and a great teacher. So it's a real honor to have Hiroshi once again for such an important APHRS SVT module. Narasimhan has been a friend, a guide, and past president of IHRS, very academic, very nice person to talk, again, very down to earth, and is a very good teacher. So we are going to learn some very good things about maneuvers, diagnostic maneuvers in SVT diagnosis. I would now, and we have Dr. Nagarajan, who is a very accomplished electrophysiologist, to help us out, and is as a guest panelist to help us out with the discussion part of it. So welcome, Dr. Venkat. And we start the meeting today with parahesian pacing from Hiroshi.
All right. Thank you, Dr. Singh, my friend, and then I'm going to share my screen. And then, can you see my slide?
Yes.
Yes, sir.
Here's the Cleveland Clinic. I relocated Cleveland Clinic 2 years ago. I was in the University of Oklahoma 28 years, and then now the Cleveland Clinic. I became the Clevelanders. And then I'm first talking about the parahesian RV pacing. Technique to differentiate between retrograde accessory pathway and AV nodal conduction and the practical tips. Here's my disclosure. Let's start with the problem, the RV apex pacing. I know everyone want to put the RV pacing catheter apex because of stability. But for the SVT patient, when doing RV apex pacing, because the Purkinje myocardial junction is located apex, rapidly going to the Purkinje system and going to the AV node retrograde. Even though if you have the accessory pathway located unsusceptible, you have no idea existing the pathway is located in the septal region. In contrast, if you do the parahesian pacing, which is the anteroseptal basal pacing, when you have the lateral conduction over the AV nodal pathway only, if you capture the right ventricle as well the his bundle or proximal right bundle capture, so the waveform, because through the Purkinje rapid conduction through the first pathway, like behind the tendon to the earliest atrial activation is located here. So therefore, the very short stim A interval. If you lose the his right bundle capture or RB capture only now the ventricular waveform from base going to the propagating to the apex, and finally through the Purkinje myocardial junction at the apical region, they're coming back to the this Purkinje system retrogradely, and finally activate right atrium through the first pathway. So in this session, the stimulus interval prolonged. However, if you measure the retrograde HA interval should be same, and the retrograde atrial activation time depending on timing the HV activation. And of course, the activation sequence is going to be identical between without his capture. You have the retrograde conduction over the accessory pathway. For example, let's say consider anteroseptal pathway. This is the RB his capture both. Just go to the pathway conduction, very rapid conduction. You see the earliest atrial activation is located anteroseptal region, and the stimulus A interval very short. If you lose the capture his Purkinje, just capturing RB doesn't matter, still conducting over the pathway. So therefore, regardless going to the apex or not, but already atrium activate through the accessory pathway, it's located here. So therefore, the same short stimulus interval, again, retrograde activation timing depends on the ventricular activation, and this activation sequence same. Importantly, if you lose his capture, the HA intervals come shorter, indicating the retrograde conduction. It's not depending on his activation timing. If you have both accessory pathway and AV node showing here, if you're capturing RB and his like here, and going through the accessory pathway and AV node. If you lose the captured his, and now it's going to the apex and coming back, but already deactivated by the anteroseptal considered pathway. But if you capture both, you see the different atrial activation sequence compared to only the capture. So therefore, importantly, you see different retrograde atrial activation sequence indicating you have both accessory pathway and AV node. It's a rule, the simple rule. Let's go the practical issue. It's important to have the reflective quadripolar, like 1 or 2 millimeter electrode spacing Here's the octopolar his catheter defectable. I know not many people using this, but this is very important. And also having the defectable parahisian pacing catheter, quadripolar catheter here. Octopolar his recording catheter and the quadripolar pacing catheter for the parahisian pacing. And also they having the lighted appendage, not the higher layer. This is like information for the lateral, the tricuspid hernias to identify the existence of the light free or accessory passage and coronary sinus catheter. And then you can have the ablation catheter. It's located like a post-receptor region. All right. So then this is the during a sinus rhythm, lighted appendage, and then octopolar his recording. You have a 4 bipolar recording, and now you can see the anterior conduction his, and this is very distal or proximal right bundle activation. So here's the parahisian pacing catheter again. This is deflectable and located more distal side of the his recording site. When gradually pull back, we increase the pacing output to get the his capture, not only RB, also his capture at the same time. Or you don't have to move the catheter much by respiration. You might have the intermittent his capture with the right bundle or the right ventricular capture. And this is our publication 2005. They have vision to how to differentiate the RB parahisian pacing. This is very complicated. To simplify, so this is the way we analyze the parahisian pacing response. When you have a RB his capture, and then if you lose the his capture, still capture RB, then you see the different retrograde activation sequence indicating you have both pathway and AV node conduction. But if you lose the his capture, only RB capture, if identical atrial activation sequence, then look at the stimulus A or local VA interval. If you're getting longer interval and the HA interval same, that's indicating the AV node conduction retrograde. Then if you lose the his, but the same interval and the stimulus A or local VA interval, but HA interval comes short, indicating there is the pathway conduction retrograde. Let's go one by one. And the question always the retrograde conduction over the pathway, AV node, or both, or you can say, I don't know, I don't care, okay? And this is the case. All right. Surface EKG, read 1, 2, AB1, lighted appendage. This is the octopolar. You have a 4 bipolar recording proximal to distal. Ablation catheter is located post-receptor tricuspid hernias. This is coronary sinus. And the parahisian pacing is located here. So you see, retrograde his activation here. And this time the after the B, this is in front of a B. So this is a capture, B and his. This is B capture only. This is B and his capture. If you take a look at the atrial activation sequence and the timing, stimulus A, earliest atrial activation is located at the septal region. Stimulus 65, 110, only B capture. If you capture both, again 65 is short. So the question is, this means what? So then look at the stimulus A interval increased when do his capture, right, from 65 to 110. But if you measure the HA interval from H to this A, 50, and HA 50, it's a fixed HA interval. This is indicating the timing the retrograde activation depending on his bundle activation. So therefore, retrograde conduction over the AV node, this time because anteroceptal region earliest retrograde atrial activation. So therefore, fast pulsar conduction. This is another case. So during a sinus rhythms, no pre-excitation. These are his recording, right appendage, his recording, CS. Parahisian pacing cycling is 550. So A is here, and then stimulus H, nicely showing a retrograde his activation after the B. So then you capture the his as well. Now his comes within the pacing artifact. But a stimulus A, 80 RS here and the receptor region, and this one, 80. Fix the H stimulus A interval is fixed. And the HA interval, when lose the his capture, HA interval is getting shorter. So indicating the timing, the A2 activation depends on the ventricle. So therefore, retrograde accessory pathway conduction. So this is a concealed anti-receptor pathway. It's no fast pathway conduction, only anti-receptor pathway conduction. This case, concealed anti-receptor. Here's the another case. Here's a lighted appendage, his region, coronary sinus, parahisian pacing. This time, area stage located highlighted appendage. Again, when you have his capture, his comes frontal B. You lose his capture, his comes after the B. Conduction time stimulus A at RS activation site, A2 activation site is lighted appendage. It's a fixed SA interval, fixed. And then HA interval, when lose his capture, is getting shorter. So this is indicating, depending on the timing of the ventricular activation, not depending on his timing. So therefore, the retrograde accessory pathway is located the anterolateral, right tricuspid annulus. It clearly shows the presence of the right anterolateral. This is an interesting case, 32-year-old female, prior failed ablation procedure. Old case came to University of Oklahoma, long RP tachycardia. So tachycardia cycling is 425, incessant SVT. And actually we could terminate it, and then we just pacing the very slow, like pacing cycling 730. Otherwise, you initiate tachycardia incessant. When doing a pacing from a parahisian region, look at the A2 activation sequence, left panel B and his capture, and right panel B capture only. First of all, the A2 activation sequence identical. If you measure the stimulus A interval, like for example, CS4, 330 is 320. Almost same, but the 10 millisecond difference. However, ventricular capture only, you see the very late his activation, but not much change for the stimulus A timing. The reason 10 millisecond difference because when the B capture only stimulus B55, if you capture B and his like a 10 millisecond longer, 65. That's the reason if we are 10 millisecond longer for the when the left panel stimulus A interval for the CS4. But again, identical A2 activation sequence and independent of his activation timing, indicating this is the accessory pathway. It's located actually it turns out the myocardial vein for this particular case in patient with PGLT. We ablated MCV and eliminate the terminate tachycardia. This is the PGLT. You see like a CS4 and the RS A2 activation, actually it's mass of the MCV. We don't show here, but then after the termination PGLT, and this is the after ablation, again, ventricular pacing. Look at here there, during the tachycardia, during the V pacing, parahisian lesion. It's identical during tachycardia. Question still pathway is there, but we just do the again parahisian pacing. Now pacing. Now the you see the ventricular capture on the you see the his activation or proximal right bundle after the B. If you capture the B and the his comes in front, so then stimulus H and A interval 145, you only ventricular capture. But if you capture his stimulus A 145, and the identical A2 activation sequence indicating this is the slow AV neural pathway, PGLT accessory pathway already eliminated. So that is the almost identical activation sequence compared to the PGRT using the like epicardial processor pathway like a CS muscle connecting LV epicardium. So this, if you take a look at the CS activation sequence, the pathway activate and the CS muscle activate this activation sequence. This is a similar activation sequence, the slow pathway activation through the right one inferior extension, again coming here and entering CS. Therefore, if you look at this sequence, almost identical. But the parahisian pacing clearly differentiate for the whether the PGRT accessory pathway or slow AV nodal conduction. And then learning time, I just spent a little bit before this is the case, the concealed nodal ventricular accessory pathway. It's published the JC from Japanese group, Dr. Maruyama. They performed the parahisian pacing, and then they're saying his capture, no, only the capture, they talk about the identical activation sequence. Okay. Then if you lose the capture, the VA interval, prolonged plus 60 millisecond, and also higher RA region 6. So therefore indicating parahisian pacing, identical reticular activation sequence, but the longer stimulus interval with loss of his capture, indicating only AV nodal conduction fast pathway. So therefore, parahisian pacing is not useful to identify the presence of the concealed nodal ventricular connection. However, I look at very carefully same tracing, and this is the schematic, okay, like a concealed nodal ventricular connection connecting through the slow pathway region. And this is the tachycardia ongoing. People report